Good evening, everyone. I'm Sherry Gleed. I'm the Dean at NYU Wagner. On behalf of all of us at Wagner, it is my pleasure to welcome you to the 25th Annual Kovner-Behrman Health Forum. NYU Wagner has a long history in public service, both here in New York City and around the globe. For more than 80 years, we've been helping our students translate their passions into action so they can make an effective and lasting impact on the public good. Our faculty conduct research that changes the way people understand and act on the most important issues of our time. Our 12,000 alumni worldwide, many of them on this call, are applying their education in a real-world context in a variety of fields, and they're making an impact every day. To make an impact, one needs to understand perspectives, such as those we'll hear in tonight's discussion. The Kovner-Behrman Health Forum presents an opportunity for the Wagner community, as well as other thought leaders and practitioners, to hear unique takes on relevant, important, and timely issues in the healthcare field. The Kovner-Behrman Forum is one of NYU Wagner's premier events, and it is made possible by the continued leadership and dedication of Emeritus Professor Tony Kovner. Tony created this forum in honor of his mother, Natalie Lieberman, who made the series possible with a very generous financial gift in honor of her son and of her parents, Dr. Percy Behrman and Mrs. Ava Behrman. Many of you in attendance tonight have also given contributions that have helped to sustain this series and related initiatives over the years, and we are very grateful. Tonight's event focuses on a timely and critical, and for us, those of us in management, very difficult topic, the Great Resignation of 2021-2022. Shockwaves from this phenomenon have been felt across the public service landscape. Employees have discovered a new attitude to work, or they feel burnout. They're leaving their jobs, accelerating their retirement plans, or actively seeking permanent telework options. Healthcare, which was already facing a predicted labor shortage, has been acutely impacted by these shifts in staffing departures. Tonight's forum will address the Great Resignation's impact on healthcare. What are the nuances that are unique to this sector? What are the potential solutions for healthcare leaders to address the persistent labor issues? What is to come as the industry continues to battle an ongoing pandemic? Tonight, you will hear from my good friend and former boss, Gail Walensky, former leader of the administrator of the Healthcare Financing Administration, which is now the Center for Medicare and Medicaid Services. From Jane Massoud, Senior Vice President and Chief Human Resources Officer for the Mount Sinai Health System, a Wagner alum. And Anu Ashok, the Associate Vice President for Graduate Medical Education and Physician Workforce Policy at the Greater New York Hospital Association, who is also a Wagner alum. Tonight's talk will be moderated by Wagner Clinical Associate Professor of Healthcare Management and Public Service, Carla Jackie Sampson, who is the director of our Health Policy and Management Program and our online Master of Health Administration program, and just a wonderful and brilliant scholar and leader. And we will close with a Q&A. We encourage you to submit your questions via the Q&A button. So it is now my pleasure to turn this over to Professor Carla Sampson.
And thank you, Sherry, for that very warm introduction. Good evening. I join Dean Gleed in welcoming you to the 25th Annual Kovner-Behrman Forum. I am Professor Carla Sampson and wear a number of hats here at Wagner, including our newest program, which is the Master of Science in Health Law and Strategy. And I'm honored this evening to moderate our panel, and for the second time in a virtual format. I'm looking forward to the 26th panel, when hopefully we'll be able to do it in the way that we do it in person. But we have a lot to cover tonight, and we really want to leave time for lots of questions and answers. So I want you to encourage you as we go through this to put your questions into the Q&A box so we can get to that. And I am joined this evening by an esteemed panel, so let's just hear from them. So let's set the stage for what's going on right now in healthcare. From your seat, what underlying pressures besides the pandemic response have resulted in the Great Resignation? And let's start with Jane, and then we can go to Anu and then Gail. Jane?
Good evening, everyone, and thank you so much for the opportunity to join you this evening. There are many pressures underlying the Great Resignation that are associated with the pandemic and with other issues. As the Dean already mentioned, in healthcare, we were really faced with a challenge around labor shortage pre-pandemic. and that has been exacerbated. I think one of the things that we need to be most concerned about is the technology has allowed us to work in a much smaller world than we have previously. And it has introduced a flexibility that has given folks the chance to think about the way they work differently. That has been compounded by the need to work remotely as a consequence of the pandemic. And people have come to appreciate that it's possible to be productive, engaged, connected, while being in very remote locations that allow a different quality of life, a different experience with family, colleagues, the ability to work from other places in the world and be exposed to culture and art and social mores that are very different than what they may have experienced previously. That flexibility and the realization that the world could change on a dime, I think, have made people far more reflective about the choices that they make. And I think the fear that came with the pandemic about, is this really how I want to spend my life? And what are the important choices that I'm making? And how do they impact my family? Are things that have made many folks sit back and think long and hard about the choices they make, how they spend their money, how they want to spend their time, and what their future really could look like if they took down some of the artificial barriers that we've heretofore viewed as permanent, real, and unchanging about work, and thought about the world differently.
Thank you, Jane. Anu?
Well, thank you so much for having me. I think I bring a slightly different perspective only because I want to comment a little bit more specifically on physicians and sort of their role in the Great Resignation from a training perspective. And I say that to start because at least in the physician training world, we've been concerned about a shortage of physicians for a number of years now. Just the latest studies show that we're, predicting a physician shortage, upwards of 20,000 physicians by the year 2030, which really isn't too far away. So even before COVID, there's been a lot of concerns about whether or not the pipeline is really going to keep up with the demand for physicians just in the very, very near future. And there's a lot of reasons for that, that were probably confounded by COVID or exacerbated by the experiences that we felt from COVID. I would say one of them that's been an ongoing issue really is the amount of medical school debt that trainees face when they're graduating from medical school and going on to pursue residency. That's really been a deterrent for people entering the medical field. Another is just the simple lack of enough residency positions to go around to meet the number of graduates. So slightly different problem, something that's always been a big priority for us at Greater New York Hospital Association and for other places nationally that are looking to really sort of build the pipeline. So that's been an ongoing issue. Burnout, I think, was already a problem before COVID. Physician burnout, clinician burnout was already sort of percolating as an issue, and really was very exposed during COVID. Just the inability to have good work-life balance for health professions across the healthcare sector, I think, was exposed during COVID. But the problem of physician burnout and the problem of physician suicide was something that was really brewing prior to COVID, and then was really truly exacerbated by many of the experiences that physicians had being on the front lines of the COVID response. And I think that's going to continue to be a problem until we really invest in that and invest in the future of physicians. And the last thing is just sort of, and we'll talk about this a little bit later, I think, in the panel, just trends in the types of people going into the medical profession. At least in New York, we've relied heavily on an international medical graduate workforce, which is like a little bit unique to New York, but not unique to some other parts of the country, rural parts of the country, and how that may have been affected in some way by a global pandemic experience, whether or not people from other parts of the world are still going to come here for training. It's been sort of a question that's been tossed around the GME, the graduate medical education space. So I think all of those pressures were there, and now we're taking a harder look at some of those issues, and from a policy and advocacy perspective, trying to see how we might be able to address those in the coming years.
Great, thank you. Gail.
I'm going to approach this from my vantage point as an economist, and therefore looking at some of these issues a little differently. Although I certainly agree with the sense of the two previous speakers that many of the pressures that are being reported and felt are issues that existed pre-COVID and that will continue as we move past the pandemic, which hopefully we are now in the process of doing. The question about what our healthcare delivery system is likely to look like in the mid 21st century is one that we haven't really answered yet, but it has profound implications for the kinds of people that will need to be trained. I spent 2.5 years in the middle of the last decade co-chairing a panel from the Institute of Medicine / National Academy of Medicine looking at graduate medical education and the fact that so many physicians who were being trained were not really being trained for what was expected to be the delivery system of the 21st century, where there would be far less reliance on primarily in-hospital experiences, more and more moving outside of the hospital, having to deal with a multicultural population, and frequently not being trained in order to do that. We're still struggling with what that delivery system will look like, how much will be in the hospital, how much will be out of the hospital, how serious are we about hospital at home activities such as the University of Utah has been promoting. What kind of impact would that have on the existing hospital structure, and what kind of an impact that would that have on the physicians and other, importantly, healthcare workers that are part of the delivery of care. As an economist, I tend to think there are lots of different ways to deliver healthcare services. We're used to seeing them delivered in one particular set, with physicians doing some things and nurses doing others, and other healthcare personnel doing them differently. But for me as an economist, there are many ways that healthcare can get delivered. And if we don't have enough imagination on our own, we can look at what the military does with their far greater use of different mixes of healthcare personnel, or what is provided in the VA and other systems, without even having to consider what countries elsewhere do, because there's so many other issues that get involved when you look outside the US. So many of these pressures were with us before the pandemic. They will be with us afterward, and it will force us to think about what kind of a healthcare system do we want, and therefore what kind of a healthcare workforce would make sense.
Great, thank you, Gail. And actually, that's a very good jumping off point for us to think about now that we've understand what is there, what is possible, and given what we now know, for us to think about as healthcare models change, as we think about how we can change care models, how will that aggravate or alleviate those pressures that we're having now? What would that effect be on the challenge? And because Jane is in the care system right now, let's start with Jane giving us that answer, and then we could come back to you, Gail, and then Anu. Jane, from your seat?
I'll tell you, I absolutely underscore what Gail just said about the differences in the care models, and along with Anu's point about the pipelines. The world is indeed going to be very different. I think we are going to be in a position where we have to approach this quite differently than we have in the past. And I think there are positives in terms of what might alleviate this from the fact that we will need to break what has been the standard model and really consider the venues for care and the personnel types of individuals who can deliver that care. One of the things we're working on now as a way to stretch the workforce that's currently available is to see how we can strip out any activity that's not tied to a particular license so that that work can be done by a different type of personnel, which allows you much broader access to talent. It also allows that talent to come from all around the world because it doesn't always need to be in person. And it allows you, I'm going to use the term sandbox, to sort of be flexible about how you do this and really be creative. That requires that you work with people who are willing to tolerate some role dissonance, who are able to step away from what has always been the tried and true approach in the United States to delivering care. How that can aggravate the situation that we're in, you have to drive on the road while you're building it, which can be pretty challenging because shifting from one model to another or one model to embracing many is something that requires flexibility of mindset, which one does not always encounter. And there are usually some bumps in the road as you build new tools, and people will need to learn to be tolerant of what's a learning curve in many respects. I would also say for individuals with an entrepreneurial mindset, there's a great opportunity. And I think one of the additional challenges might be what our policies are going to look like, and are they going to change along with regulations in a way that supports the needed movement. I think there's a lot of tension between the aggravating factors and the alleviation factors, and it's going to require collaboration, a broad mindset, and people willing to think outside the box.
Thank you, Jane. Gail?
Hard for me to argue with the issues that Jane just raised. I especially liked the phrase she used, driving on the road while building it. I think that is a very good image of what we're going to need to resolve and encounter as we go forward. People have found the ability to work from different venues during the pandemic. Somewhat less true for physicians and other people delivering direct healthcare. My daughter-in-law is an OB, and we frequently laugh at the concept of what can be done remotely and what has to be done in person. And of course, when you're talking about healthcare delivery, it does tend to require much more of a hands-on position. But too many people have realized that a lot of supporting work, and even some of the work, of course, that physicians do, that has been taken up through the very substantial increase in telehealth, does not always need to be done in person in order to be accomplished. We're going to have to make these decisions about how much we, patients, physicians, regulators, payers, want to change going forward. And again, putting my economist hat on for a minute, one of the challenges for groups that are not part of at-risk payment groups like Kaiser and Geisinger, where the amount that will be received by the delivering care organization is set in advance, is how are we going to reimburse for care that is delivered remotely? Unlikely that we will continue, as was done during the pandemic, to pay the same for in-person and remote visits. As an economist, that part is relatively easy for me to justify. The difference of what should exist is much more challenging. How do we value these different types of visits? What will allow the care to be provided as appropriate, where appropriate, so that individuals that are providing the care don't feel like they are being unfairly treated. To the extent we continue the move either in Medicare toward Medicare Advantage or in other healthcare systems where the group providing care is at risk, this becomes an easier question to resolve because it becomes more or less what the delivery organization thinks makes the most sense, provides the best care, and is the most efficient. But to the extent we still have a substantial fee-for-service component, and I suspect that will be a part of our future for quite a while, it becomes much more challenging. What's appropriate, what's fair, what's not.
Thank you, Gail. And did you have anything to add here on what this might mean?
I think the only thing I'll comment on, just because I have sort of less expertise on the care delivery end of things, is how we're going to, modify our educational models to better prepare the future physician workforce for the things that Gail and Jane just talked about. And I think that's really a very important thing for folks to think about. How are we going to relook at medical education so that students entering into residency training programs are prepared for this new way of delivering care, whether it's moving more into the outpatient setting, which has been a trend for a number of years now, or really out into the communities, which is something that we saw happen quite a bit during COVID, and working more closely with community-based organizations. How is that kind of integrated into their education upfront as medical students? So I think that that's something to really think about. I was listening in on a discussion a couple of weeks ago about how, at least from an undergraduate medical education perspective, we really haven't seen a major overhaul of the traditional 4 years of medical school training. And if anything is going to push that, it could be something like a global pandemic that really makes you think about how we want to sort of rework educational models in response to what changes are going on within the delivery system. So I think that's the only comment I'll make, because I think Gail and Jane covered most of it.
Thank you. And that's a very valid point, because remember, we're thinking about a situation where we have an existing shortage. It takes a very long time to prepare clinicians to add to this. So it means that we really need to think about what the educational models are going to look like in the future so that we can try to meet this challenge. But in the middle of all of this, we have the patients, right? We saw in the pandemic that we've had to defer some treatments because we didn't have the people, and we have these pressures of other things that we were looking at. And then as people start burning out and thinking, we're not going to stay, what ethical dilemmas will we face if we can't solve these challenges? And what might be the implications for healthcare quality? And I hate to keep picking on Jane, but what do you think, Jane?
I think we need to be very mindful of the potential for moral and psychological injury for the individuals who are providing care, and how to deal with what could become post-traumatic stress disorder over time if there is sufficient exposure to situations where you are positioned to make decisions that are asynchronous with who you are as an individual. And I think preparing for that to the degree that you can by providing just-in-time training and support in the workplace is key to be able to help people appreciate the fact that there are these decisions that may need to be made. They are not the decisions you would prefer to make, that collaboratively we will do the best we can. I think there needs to be a tremendous focus on teamwork and we, as opposed to an individual clinician making that decision to moderate some of the negative impact that could occur to the care provider or individual making those decisions. I think that is key to be able to retain the workforce. And I think being very careful about how we select the people to do this work is key. I think that what we've seen is that individuals who have heretofore been very resilient and perhaps shunned the need for supportive care in the workplace are rethinking that, and individuals who are more brittle find it very challenging to be in this space. So taking the time to try and be selective and thoughtful about really bringing to the fore what's required in some of these roles is going to be key. Providing that support and presuming that it's needed way before it's asked for, and soliciting via outreach that continued care rather than waiting for the individual to come to you and say, I need help, I think are all things that are key to moving forward effectively.
Thank you, Jane. And how you mentioned a little bit about this before, but how is this showing up in curriculum and preparation for
It's interesting you mentioned that. I was just on a call last week where we are talking with the Phillips School of Nursing faculty about how we would build that into actual coursework. In anticipation of the fact that we're aware of the fact that those challenges are going to be forthcoming and that we really need to do some developmental work around curriculum to prepare our students accordingly.
Thank you. Anu, anything to add about how this is coming down to preparation?
Sure, and and Jane, coming from Mount Sinai, has really been at the forefront of so much of this and built so many structures to support student trainee wellness. And I think it's a real model for what our academic health systems have to invest in. I couldn't agree more. I think that, a well workforce is going to provide high quality care. So we have to think about that. And it does start early on. I think it starts in an undergraduate medical education level, and has been getting a lot of attention over the years, thankfully, and should continue into graduate medical education and onwards. And there's a number of initiatives around the country that are aiming to incorporate wellness and well-being into curriculum. So I'm really happy to have seen and observed that really grow in terms of the level of importance over the years. On a slightly sort of different note, I guess, with respect to some of the ramifications to healthcare quality that were exposed during COVID, I think unrelated necessarily to burnout has just been the more obvious healthcare disparities and real discrepancies in access to care that were made really made very, very obvious during COVID. And, from a policy perspective, I think people, at least in my role, are thinking a lot about how we're going to be able to get physicians into some of those areas where access is a real problem, and where quality can really suffer when people are not able to access the kind of care that they need. So how do we get physicians to train in those areas of the country or even those parts of the state? So again, slightly different, but I do think that's important to raise when we're talking about quality, because I think just the disparities alone have been really exacerbated over the last couple of years, and it's something that we need to pay attention to as policy thinkers.
Thank you, Anu. And Gail, about the implications if we can't solve this, especially around healthcare quality, what would you say?
I think we need to recognize that we are just beginning to see the results of the effects on quality and on outcome differentials. I was thinking about reports that are already occurring that people are coming in with later stage cancers than they had previously, presumably reflecting the number of screenings that were postponed or not done at all as a result of the pandemic. And it is a reminder that even when you're in the midst of a chaotic moment, trying to give planning and thought to the downstream implications of decisions that are being made is very important because of the repercussions that can result. It is hard not to be frustrated thinking back about what happened in the late spring of 2020 and early summer of 2020, when not knowing what the COVID numbers were going to look like, at least in the Washington area. I'm going to assume it was not terribly different in New York. Basically, everything other than emergency care and not always emergency care and COVID-related care was shunted aside. And as it turned out, much of the expected demand never occurred. But in the meanwhile, people with cancer and with serious coronary disease and other not generally postponable medical conditions found themselves being shunted aside for several months before it was clear what could be done and what really needed to be postponed until we were in less chaotic times. It is obviously understandable that when you're in the middle of what turns out to be a pandemic, it is hard to predict what is going to happen in the coming weeks. But we need to learn from some of the decisions that were made during this period that in hindsight turn out to have been unfortunate decisions because it is highly likely, at least in my view, that we are going to have more viruses in our future. We seem to have moved into that position. We have gone through several viruses in our past, not just the SARS-2 COVID, but Ebola and MERS and other viruses. And we should try to learn from well-intentioned, but in the cool light of day, turned out to be less than desirable decisions that were made, not to point a finger of blame, but to be better prepared for the next one that comes our way.
Thank you. And actually thinking about that pent-up demand, thinking about what staff are going through right now, and thinking about what the response might be for the next wave of things that we need to respond to, be they mass casualty events or another virus. What are some of the strategies that forward-thinking organizations are putting into place? Jane mentioned earlier the task shifting and making sure that people are practicing at the top of their license, but thinking even more long-term, what else is happening in organizations? And we also mentioned this in passing, and we could dive deeper into that right now. What regulatory conditions would be required for these initiatives to be successful or to become standard? And let's start with you there, Gail.
An issue, it's an issue that I have been thinking about and frustrated with at least the last 30 years than I can remember. I don't know, it may well have been before that. And it has to do with the trade-offs of keeping medical licensing at the state level. It is our tradition, but it really complicates a lot of life. It would be much easier if we could at least move some of the licensing to a national level so that we could allow for the freer flow of individuals, both electronically and in person, to respond to the needs where they are. I am respectful of traditions, but this one seems to be one that has gotten in our way more than it has been helping, at least as of late. And we found with the Affordable Care Act that what had been traditionally state issues with regard to health insurance and health insurance laws could be moved to a national level without having the country grind to a halt. I think this is an area where we really need to give serious consideration to how we can allow for the freer flow of individuals where needed, when needed, both across state lines, but across occupational restrictions as well, which of course we actually see when we look across different states because they tend to be very particular and peculiar to individual states with their history. It's again where when we look to the military, we may be able to learn some things because they have relied much more on national licensing rather than primarily state licensing. This will be a political hot potato. I don't want to minimize the challenges, but I think we may be forced into that position if we'd like to do better the next time around. Not that we didn't actually do pretty well, all things considered, this time around, but I think the expectations on the part of the public are going to be even higher and more demanding the next time this happens.
Thank you, Gail. That would be quite the hot potato, but I see where we need that. Jane, do you have another hot potato for us?
Well, I'd like to continue the hot potato that Gail started, because if it wasn't for the fact that the governor had allowed us the flexibility to bring in individuals from other states, we would have been in a horrible predicament for the first wave. It is only because we had an influx of professionals from outside of New York that we were really able to manage as well as we did. So I give thanks every day for the fact that that was the case. And I would have to absolutely emphasize what Gail had to say on that front. It is something that we absolutely need to grapple with. The other thing that I think is important is that we need to really focus on the team approach and career laddering in the workplace. The team approach, because none of us alone are as good as all of us together. And one of the things that we saw at Mount Sinai during the first wave in particular was that we often had physicians working alternate shifts to help the nursing staff because they were stretched so thinly. And it was wonderful to see that. And it was wonderful to see some of our docs who specialize in areas that were really not part of the constellation of COVID learn from their colleagues about how they could step in to help too. So the fact that, you know, we're all in the same boat here, hopefully rowing in the same direction, is something that I think is important to formalize. And I think we'll need to do that because of the dearth of individuals selecting these professions going forward. I think career laddering to go along with that, to give individuals the opportunity for growth in the workplace, and in so doing require that there's additional education and training as part of that effort, so that you have a ready pipeline for succession planning and individuals moving up into the next rungs of an organization, a profession, et cetera. The last piece I'll mention is that we are working on an effort with the New York CEO's Job Council and some of their associate organizations to begin some internship programs, bringing the basic science orientation into high school, because we really need to bring awareness of the need for healthcare and those skills and interest and opportunity for growth and learning, and for a calling for those people who feel that way about the delivery of healthcare. at a point in time when students are beginning to think about what they want to do and who they want to be and how they want to grow, because we need to nurture that from a very early age to begin to inspire people about who they can be and how they can contribute and where they can make a meaningful difference. Lastly, even though I said I was lastly a minute ago, one last thing is I think we need to emphasize the need for opportunities for people of color. The populations that we're caring for are diverse. People feel a greater sense of comfort when they're cared for by someone who looks like them, sounds like them, appreciates their same cultural values. There's a resonance there. There's a trust that goes back into quality of care, the patient's willingness to follow the care regime. And I think developing pathways and opportunities for growth and mentoring and upward momentum in the workplace is essential. And I'm proud to say that we've made that a key cornerstone of the work that we're doing at Mount Sinai.
Thank you so much for adding that, Jane. Anu, what about you? Do you have a hot potato for us?
I don't have a hot potato, but I love the hot potato of license portability, something that I've felt passionately about for a while, at least since I've been at Greater New York, and excited to see language in the proposed New York State budget to sort of move that along, at least through maybe through the joining of the Interstate Medical Licensure Compact, which would allow physicians to easily practice across state lines as well as nurses. So I think that to me is sort of the low-hanging fruit when it comes to these things, and that would be a huge help. And that was really tested during COVID when we needed to bring people in from other parts of the country quickly to hotspot areas. So I think that it's maybe a little politically fraught, but I think that's really important. The other two things I'll mention, sort of from a regulatory perspective, and there's been quite a lot of movement in this area, so I think it's promising, is just flexibilities around telehealth, which is related to that. So that's moving really quickly. The advent of telehealth was huge, explosive during COVID, and I think remains to be seen what where telehealth will go in the future, but it's going to be there. So I think that the more easily accessible telehealth services are for both providers and patients, the better. So from a regulatory perspective, I think as much flexibility, and that translates all the way down to the reimbursement and pay parity models, is hugely important. And then related to both of these things is really just more streamlined credentialing. That was a big thing during COVID also. There's a lot of opportunities for administrative simplification when it comes to the credentialing of healthcare providers across the professions, especially in the medical profession. So again, the better integrated those initiatives are, I think, the more easily we'll be able to be nimble as a healthcare workforce.
Thank you, Anu. No hot potato, but just thinking about all the things that we would like to have happen, which is like a wish list of what should happen so we can really get past this. Thinking about what we're dealing with right now, and people are still in the trenches, still thinking, maybe this is not something that I want to keep doing. If we think about what are more immediate solutions, right? If you had your magic wand and there was going to be just one policy change to relieve the current pressures, where would you start? And Anu, let's start with you. Where would you start? There was just one thing, magic wand. Yeah.
Gosh, I don't know if there's one thing. It's more of an ask, I guess, of the entire industry, is and it's related to what I just talked about, is we just have to be more nimble, I think. So I know that's a little bit broad and I don't mean to be vague about it. I just think that that we need to be nimble with what we're allowing people to do. We need to be nimble about how we're training. We need to be nimble about what care delivery looks like. So we should use this, I guess my plea would be that we should use this as an opportunity to become forward thinking. And it's okay that there were things that didn't work so well before, because we now have an opportunity to do things better. And so I think there's been a lot of attention on things that went wrong during COVID, but we should really think of this as an opportunity for innovation and use those opportunities for innovation to be nimble and flexible with just within the industry overall. I don't have like one answer, but I think that at least from when I start to think about what are the lessons learned, at least from a GME and physician workforce perspective, though that's the first thing that comes to mind.
Thank you. Jane, what should we do? One thing.
If I was to pick one thing, and I think we've talked about the two things that I would originally choose, and that was physician credentialing and licensure portability. The other issue would be standardization of educational requirements. And I'll say that, and I'll use lab technicians as an example. In the state of New York, you're required a bachelor's degree to be a laboratory technician, which is a role where you earn about $55,000 a year. And as you might imagine, there are many people who might be interested in laboratory work, but not at that salary and not after they spent the money to get a baccalaureate degree. So I would love to see two things. One, a standardization of educational requirements, and two, a national effort to plan for the next event, because we are sure we're going to have one, because we've had quite a number of them. Gail outlined that clearly a bit ago. And to talk about what is the plan for moving back and forth to areas of need in some kind of rational way. I think that a lot of what we did in this circumstance was more hit and miss is the wrong descriptor, but it was go to as many places as you can and see where you can get leverage to move people in and out of spaces of need. The military is very skilled at doing a lot of these things, and I think taking some of their paradigms and applying them to healthcare emergency would be of great benefit.
Thank you, Jane. Gail, one thing.
It has to do with the regulatory authority and licensing, which I think both Anu and Jane have raised. So many of the challenges that we faced during the pandemic basically ultimately lead back to licensing and regulatory being a state-controlled activity that we should at least have during public health emergencies, an alternative environment. That's if we don't want to be too bold, and otherwise make it not limited to a public health emergency when we would have a more centralized licensing and regulatory authority available to meet the needs that we're facing. We made it harder than it had to be for ourselves during this pandemic in many areas because most of it seemed to move east to west, although California frequently got hit very hard, but otherwise there seemed to be in general an east to west geographic movement of the pandemic. By the time you got to the middle of the country, the Midwest, or the eastern part of the Midwest, you had already learned a lot that could be passed on to people who are on the front line and providing services. Seems a little arcane as a way to be behaving in the 21st century, to have that kind of geographic reliance and change in learning. I think we need to sit back and try to have lessons learned so that we are better prepared for the next virus that comes our way. Even though, again, in all fairness, to particularly states along the East Coast and New York in particular, that just got slammed with numbers and with demands being placed on the medical care system and the people who provide care there to respond and then think about more planning that might have been useful. We can expect this to be in our future, and it really is incumbent of trying to get the warring factions, and this is a very touchy and sensitive area, I realize, to be willing to sit down, lay out some options, and think about the circumstances under which they would at least be willing to waive or relax restrictions that are otherwise in place. That seems to be the minimum that the rest of us should demand that the healthcare system do.
Thank you, Gail. And so in all of those, political feasibility is a huge part of that. What should we do about that issue? How do we get around that big roadblock of it? Always comes down to what is politically feasible. What do you think, Gail?
Well, that is ultimately the question, because in our market-based democracy, ultimately we can only do those things that the American public or active portions of it are willing to tolerate. We don't do ourselves any favor if we pretend that these are decisions that can be made outside of the political environment, or beat ourselves up, as we regularly like to do, about why other countries do it a certain way, but we can't. My usual response is because they're them and we're us. And I mean, that's doesn't always come across as serious, but I actually mean it very seriously, that countries and states can only do those things that ultimately their citizens are willing to support and back. We need to be better prepared through a combination of state, local, and national decision-making with a sense about when and under what circumstances we might want to turn to the military for support, who are better at logistics than most other groups. How can that be made to work effectively in a democracy? We do that on occasion when we have natural disasters, frequently weather-related disasters occurring, but it's always seems to be like a big challenge, although there is a known power structure that needs to be followed depending on the state in order to activate those forces. All of us seem to be in agreement that we need to learn from our experiences, not that we did so badly, but because of the expectation, we'll have an opportunity to do it again at some point.
Thank you, Gail. Jane Renew, how do we get past these roadblocks?
I guess advocacy, good policy discussions, data-driven discussions, those kinds of things. I mean, that's what we do at Greater New York. So to really try to help navigate some of these things. And I think that having experienced a pandemic and being at the epicenter of it here in New York, we kind of did that. I mean, we use data to make public health decisions. And so I think that it really set the tone for how we're gonna, at least, from an advocacy perspective, figure out how we want to get messages across. And I think that's a really important vehicle for that. I'll leave it to Jane to add anything else.
Yeah, thank you. Jane?
I think that's one of the toughest things to solve. It's been abundantly clear how polarizing and political COVID has been. The number of people who think it's a hoax, which confounds me. But I think trying to find a way to link those groups that see the need together as a collective and use that as a point of leverage for advocacy as what I think has some opportunity for possibility. I think it's going to be tough to resolve because people's feelings are incredibly strong about whatever their particular position has to be. And I think somewhere in there, we need to find a way to help folks think about more about the other than about the me, because a lot of this had to do with the other. And you have to have that awareness, that ability to step outside yourself and think more broadly.
So could all of this, in terms of what we've seen, what we know needs to happen, how we've tried to respond, the patchwork of responses that we put in under the public health emergency, could be a tipping point, right? And in reaction to crises, we get to be innovative. We get to kind of solve things and move forward. Look what we've done for how quickly we adopted telehealth. Let's think about the positive. Could there be a silver lining to all of this? And if there could be one, where should we look? How about you, Jane? Where should we start looking for a silver lining in all of this?
Well, I think right where we live, because I was charged with finding 1,000 employees who would be willing to work way before the pandemic was on anybody's mind. And talk about an uphill battle. I can't do this, I can't do that, I have to be in my workspace. 72 hours after the first patient arrived at Mount Sinai, we had moved 10,000 people to working from home. So I think what we've learned as part of this is that the boundaries that we, I think, artificially place on things are far more permeable than we expect them to be. And I think taking a sort of scientific approach to pushing on those boundaries to see where we can go and doing it while the iron is hot, because we made a lot of progress. This is the time for innovation and to look at what we've done and how far we've come, and to continue to push that forward and do it in a very mindful and intentional way. That this growth has been positive in many respects. We've learned many things. We've learned how to step out of some roles and into others, often overnight. We've learned how to be innovative. And I think that because of the dire situation in which we found ourselves, people didn't think about all the reasons why you couldn't do it. They thought about the fact that you had to do it, and therefore there was no choice. There are an awful lot of smart people that are in the healthcare and related professions, and they are in many respects dedicated to the work they do with what I believe is a special calling. I think galvanizing that effort and pushing it forward is something that we need to do. And the opportunity is ripe right now for that to happen.
Thank you, Jane. Anu, we're looking for silver linings. What's the bright side?
I think there are some. I think there's so many lessons learned, and it's an opportunity to innovate, like Jane said. One of the things that I've been thinking about, and actually one of the participants posed a question about it, is really, shortening of training, and whether or not that's an option for the future. Something that has been looked at least in the GME space, and lots of different, from lots of different angles. But, during COVID, a lot of our medical schools allowed their fourth years to graduate early through waivers of certain requirements, and be on the front lines of the COVID response. So, which I think was hugely helpful for some places that were seeing huge influxes of patients and just extra hands on deck. So what does that say about that year of medical school, or at least that part of the year of medical school? Think about that. We should think about it. I'm not saying it should go away, but I think it just provides an example of something to think about. And as the pandemic progressed, a lot of our residency training programs, we're constantly redeploying residents to different parts of the hospital and giving them lots of different types of tasks. So what does that mean for the kind of training that they're getting? And maybe it's not the future, but it's something to consider. It's something to look at. What did they gain from that? Some of them were redeployed to, vaccine clinics. Some of them were put out in the community. So, I think we're at a crossroads here where we were forced to have people fill different roles, like Jane said, and some of it worked, some of it might not have worked, but we should survey people and find out and use that knowledge to think about innovation and educational redesign across the health professions. Because, I think, like I said earlier, for your earlier question, I think my dream is that we're just nimble about these things so that we can respond better to future emergencies. So I think there's many silver linings, but that's one of them.
Gail, it's the bright side.
I wouldn't have expected as much agreement on some of the fundamental issues that have been raised tonight as we're seeing. The points that Anu just raised are ones that I agree with strongly. If we look at what has happened in medical school and residency programs, the tendency has been to keep everything that's been done and add on those areas that aren't yet adequately handled. Of course, that makes no sense. It's just easier not to have to fight the battles of taking away the favorite parts of somebody who's on the medical staff or medical faculty or in an important power position while you're trying to redesign a curriculum or a training program to make more sense for the middle 21st century, because that's about where we're going to need to head if we really want to do any serious change in terms of the training. But we've been forced to learn that the system can be much more flexible than we normally think of it as being, and we shouldn't lose that opportunity to follow through on some of the changes, including asking whether or not that fourth year of medical school, which seems to mostly serve as a buffer between the clinical years and when people decide where and what they're going to do in residency, surely we can find a better way to make use of that, either in training or providing service to the communities where people are residing. It's hard to get people to make tough political little p decisions like that when they're not in the middle of a crisis. But we've learned a lot in these past almost 2 years. We should take advantage of it.
Thank you, Gail. And actually, that's a really nice segue into a question that's come in based on what we've learned in the last 2 years, as in, and this is specifically for you, Gail, if we can have the same outcome using telemedicine as we can have using the traditional method, why should you not reimburse at the same level?
It depends why you think reimbursement occurs. It ought to be something about the time and resources used. And whether or not it's appropriate if you have a less resource intense experience, that you should reimburse it at the same amount. Most of the telehealth exchanges do not require as much time or resources as actually providing in-person care. But to the extent that they do, that's a fair question. The better direction is to try to move away from fee-for-service reimbursement on an encounter by encounter basis, we will do much better, both for the delivery system and for the patients, if we can agree on the cost of providing a bundle of care, either to take care of a particular illness or for a period of time, rather than having what seem like endless debates about the appropriate reimbursement for a particular encounter in a particular place by a particular type of medical expert. Been there, done that.
Thank you, Gail. And we have quite a few questions coming in. If you do have a question, burning question you want us to answer, now's the time to get it in, because we're running up to, I know we do this run out of time. Here's another one. And this is really about that remote work preference. So considering the Great Resignation, most of the non-clinical staff were 100% remote during the pandemic. And the idea of coming back to work seems to make not a lot of sense. And one push has been that the idea is to support the clinicians by showing up. So considering the statement of potential PTSD for clinicians, is there any validity to making non-clinical staff come in just for the visual to support the clinicians emotionally? And if so, how does that impact available talent? That's an interesting question. Yeah. What do you think?
I wouldn't buy it. The answer is no. As a non-clinician, no, I don't think that's a good enough reason.
Jane, would you do this at MSK?
I have to agree with Gail. I do think, however, that leaders who have the flexibility to be remote, work hybrid, or be in person should spend some time in person, because a leader's role naturally must include spending the time to support individuals regardless of the type of work that they do, in addition to assuring that there are sufficient resources to provide additional supports to those folks who have had a particularly challenging time.
I see another question that is something that I was talking about in class last night. So how much of this resignation phenomenon is due to large healthcare organizations themselves and the autocratic or culture busting behavior that is instituted when they take over hospitals and their practices? So really about, how much is it culture?
Well, it's happening everywhere, not just in hospitals and healthcare. I mean, when the term the Great Resignation is being used, it's not being confined to healthcare. It's just being confined. It is being used to reference the change in how workers are looking at their jobs, how they want to spend their time, what they're willing to do, what they're not willing to do, the search they're going through. I'm not quite sure what they're living on while they're doing all this activity. I wonder whether the gray economy is bigger than we think, since we're not a country of big savers. But it is clear this is not in any way confined to just healthcare.
I totally agree. I actually think from an industry perspective, healthcare mergers and consolidations provide opportunities for employees. I mean, certainly they could be a little politically motivated, I guess, for lack of a better word, and certainly culture changes. But I think that in the larger scheme of things, that it provides more opportunity. So, and I don't think that what we're seeing in the workforce is unique to healthcare, just like Gail said. I think as a society, we need to look at all of these issues sort of across industries, and what cultures people are looking and seeking for when it comes to their jobs. People had real reckonings about that over the last 2 years.
So related to that, and I'll say this before Jane jumps in on that, are there other industries that we can learn from?
Not yet. I mean, maybe, but
I can tell you that I'm much challenge right now finding IT staff as I do finding some of our clinician staff. And I think IT is a great place to benchmark in terms of the fact that there's a lot of tech work that can be done from remote locations. I can't tell you, we have overseas staff who work the hours we're not working. So the folks we have actually that work for us in India are working at night when the standard 9 to 5ers are sleeping, so that you have the opportunity to have a 24-hour workforce without requiring your own staff necessarily to be working around the clock here. I think that there's great opportunity to think about what's that hybrid model that really works well. There's value to being able to be with people in person. There's clearly, we've done a number of studies, survey-based studies with respect to the fact that people like that in-person opportunity. They just don't like to be mandated to have it. And it seems that 2 to 3 days a week is something that people tend to gravitate to, and they like to have the flexibility of not commuting and not spending an hour or two, going back and forth to work. That really makes a difference. People with children in particular seem to find much greater comfort in their ability to be flexible in the time that they spend. And I see people who are not part of families and do not have children much more interested in being in the workplace. So I think the ability of a successful organization to embrace a range of possibilities based, of course, upon the requirements of the job puts one in a really good position to make the most out of this particular silver lining.
Yeah, I agree. I mean, I think I think that, healthcare will never function like a startup or like a tech company. But one of the things that's been valuable for those types of places is that they have always typically provided flexibility for their workforce, which is something that's not been typically provided in the healthcare industry. Because the healthcare industry tends to be a little bit behind the times a little, at least from my experience, I guess. So I think that, being able to treat workers as individuals and recognizing that people are individuals and have life circumstances will only benefit leaders of these organizations. And I think that if anything, some of these some other industries that have thought about that first will have some lessons to learn, but I don't know if anybody's really solved it. There's still so much work to do around just, between childcare and caregiver needs and things like that. I think there's a lot still that needs to be done, and I think that applies across industries.
Great, thank you. And there's a question here that I kind of like because it goes back to some of the history and of what happened and where we've landed. This question goes, the discussion of medical students and trainees leads to the overall question of the role of trainees, right? Their worry is that it reinforces the notions that trainees are often used as hired hands versus trainees and still learning. This feels like a possible step backward pre-Flexner when doctors trained as apprentices, not always in formal training programs. How do we balance those competing priorities? The fact that hospitals rely on trainees to provide service versus truly learning and acting as trainees. How do we balance that?
I want to just make a distinction between what may have promulgated this question or comment and maybe what the commenter is asking about. I think that during COVID, trainees were asked to step in and do a lot of different tasks to help with the COVID surge, as were many members of the healthcare workforce, because
Right.
we were in an emergency situation. I'm certainly not saying that that's the way that they should be trained moving forward. In fact, what I'm saying is the opposite. I don't think that they should ever be used as service line providers, but I do think that they were exposed to an area that I would just sort of broadly refer to as sort of public health, in a way that they may not have been under other circumstances. And I think that it's more thinking about that and how that should be incorporated into training than taking a step back and having trainees provide some of the more service-oriented things that we at this point have many other members of the healthcare workforce very specifically assigned to. I think it's more about the things that they saw, health disparities, access issues, using telehealth. Those are the kinds of things that they got involved in during COVID that I think are really integral to the future of medical education, not necessarily, pushing patients from one room to another. That was an acute situation. I think that there were a lot of different facets of the industry that they had to learn very quickly. And I think that in the long run will make them more well-rounded providers. And I think those are the things that will be valuable to look at when we're talking about reorganizing medical training.
I'd like to add to what Anu said in that one of the things I saw as the pandemic began to escalate is that our clinical leaders made videos for individuals who had specific expertise to share that information, to make it an educational experience. And our chairs actually stepped up to be team leaders to create a learning environment as part of the clinical situation. So I think it's not, I agree with Anu about service line providers. It's not what we're looking to do, but I think learning on the job in your role with actual patient populations in the time of a crisis has value to it. And I think that's true for nursing. I think it's true for physicians. And I think that there's real value to come from that. I'll also tell you that our medical students routinely volunteer to participate when we have issues like this and step up and ask to be included. And I mentioned earlier that we had a number of residents who agreed on their free time to sign up and help the nurses to deliver care because of that commitment to the patient. So I think the way that you frame the opportunity has real value and meaning, and it needs to be done from the standpoint of a learning opportunity, preferably with resources real time available to help frame that teaching moment as an opportunity to improve skills and knowledge.
Residents are learners. That's their number one job. So.
And physicians and senior nurses are teachers. And if you put them together, you can really end up with some synergies that are very positive.
Agree.
What about other clinicians? We haven't mentioned, for example, physician assistant or any of the other frontline providers. What could possibly change in the way they are prepared to prepare us for what's to come? I know, for example, during the public health emergency, we relaxed some of the standards around supervision for them. Is there an opportunity there?
I think that we relaxed some of the provisions around roles, but not necessarily supervision. I would say that the supervision continued and that we put folks into a team-based model so that individuals who had greater experience were partnered with those who had less. I'll also speak to the fact that we have begun incorporating pharmacists into routine rounding and day-to-day care. And the people who I hear speak most glowingly of the pharmacists and their role in that regard are the physicians, because the physicians speak to how fortunate they feel to have somebody with that type of pharmacological knowledge to really get into the care discussion and be sure that the polypharmacy that many folks are on is something that really is in the patient's best interest, and are all of those things and their intended and unintended consequences taken as part of the care pathway. And I think that extending the way that we did has benefit, is also has the opportunity to be problematic. And I think that leadership's presence, involvement, and reframing at the end of each shift or the end of each wave We do a hot wash to talk about what went well, what didn't go well, what we should do differently the next time, what things we should work to continue to ensure remain in place, are all things that we need to continue to do.
And so I think we have time for one last question, and I'd like the question of to both of you, since you're a Wagner alumna and working at the forefront of getting us past this, thinking about the preparation for people who want to be just like you, people who are thinking about, who are in programs now at Wagner, people are thinking about Wagner as a place for that education, to navigate this landscape that we were predicting is going to happen. What are some of the competencies that they need to arm themselves with?
Well, I would start with the fact that being a lifelong student is key. To see yourself in the role of that person who's always looking to expand knowledge. And sometimes you expand knowledge by teaching, because the people who know things the best are the ones who've learned how to teach it to someone else. So I think making yourself available, asking questions, reaching out, keeping yourself open, being willing to learn that next new thing, even if it seems backwards and difficult. My grandchildren are far more adept at technology than I am, but they're pretty patient with me. So sometimes they're the people that I go to learn how to do the next big thing. But I have found that most healthcare institutions have a incredibly wide array of educational opportunities. Show up. Go to some of the things that you might not attend, be part of a dialogue, join a group, find somebody that you respect and admire and ask that person to be your mentor. Reach out, read. Those are all things that I think are key to keeping that forward momentum and keeping yourself relevant, and having a wonderful time, because the best thing you could do for your mind is enrich it and expand on the knowledge that you have. And I will say I credit Wagner with giving me a wonderful foundation for the roles that I've been able to have since I graduated.
Thank you, Jane.
Yeah, I agree. I mean, I think we're always going to have so much to learn in this space. I think that advice I would give is one of the things that became very obvious during the last 2 years was that the healthcare industry at large, the hospital industry, namely, had to work so closely with both city and state government in a way that they'd never had before, in order to protect patients and protect the public safety. And so I would say there's a lot of value in understanding how city agencies and state agencies work. So much of that I learned just from working at Greater New York. But as graduate students, and early careerists, I would say, even if you have long-term goals about moving into the private sector or long-term goals about doing healthcare technology, understanding how what type of oversight and authority the different agencies have, and the importance of having open relationships with people at all levels of government is something that will really just help you in your career and help you have a better understanding about how to approach regulatory policy, legal issues that really came to a head during COVID. And I think the healthcare industry at large is huge. Depending on what area you want to go in, you may never ever decide you want to work for the Department of Health, but you should know what they do, because you never know what that might actually impact what you do on a daily basis. And if anything, going through a public health emergency of this scale really just highlighted that. And so I think, to the extent that you can just have informational conversations with anybody that you know that works either at city or state DOH and understand what they do and try to know a little bit about their operations and what areas of responsibility they have, and would be really, I think, really helpful. I wish I did more of that at my early stages of my career. I think it would have helped me a lot. So just a little word of advice.
Thank you for that advice. And so in closing, as we get to the end of the 25th Annual Kovner-Behrman, is there anything that we did not mention that you wanted to leave as parting words of wisdom for our attendees?
You're entering a great field. Good luck. We're gonna need more leaders, as we face more and more challenges in the future. And you're in a great place. I always valued my experience at Wagner and continue to do so.
I would echo Anu's comments. I found my education at Wagner to be not only grounded thoroughly in theory, but also very pragmatic. And I think that availing yourself of the access that you have to learning, it's a safe place to make mistakes. So take a risk. Really spend some time getting to know your professors. And Anu is quite right. Looking outside very broadly at the world and those relationships in city and state government is key. And I think that availing yourself of many opportunities is a great way to go. I wish all of you great luck in the future.
Thank you both. And I know the time just goes so quickly in terms of, time flies when you're having fun. And although this was a very heavy topic, we really did enjoy talking about it. And on behalf of the faculty, other alum like you and staff and students here at NYU's Robert F. Wagner Graduate School of Public Service, just want to thank you for sharing your collective expertise with us this evening. And your remarks and responses have certainly helped us get a wider frame on this healthcare challenge. So I'd also like to thank our attendees who are with us this evening for joining us. And we really do look forward to your continued engagement with us at other Wagner events as well, and our 26th Annual Kovner-Behrman Forum, which will be in 2023, and hopefully it will be in person. So, Dean Gleed, is there anything you want to add as we close out?
Just want to thank everybody for participating, and I look forward to seeing you all in person next year. Take care.
Thanks, everyone. Take care.